Morning. So, child abuse lecture. Not always the fun ones. No fun pictures. But important stuff. Especially depending on where you work, you might not have a PZR with a 24-hour social worker, so you probably have to think about and do all this stuff by yourself. All right. Some boring stuff first. So 1974, Congress passed something, CAPTA, Child Abuse Prevention Act. They amended it in 2010, so there's federal legislation. They define child abuse as any act or failure to act resulting in death, physical or emotional injury, sexual abuse, exploitation, or imminent risk of harm, which can be used to define a variety of things. Involving a child under 18 by a parent or caretaker, and caretaker is also a very broad definition. Daycare worker, someone who's watching the kid for an hour that the parent gives caretaking responsibilities for. New York State obviously went above and beyond that and passed their own set of legislations for state law with huge definitions, but basically says the same thing. An abused child is someone who an adult is legally responsible for, and either by an act or a failure to act leads him to harm or risk of harm. So the wording, by failure of act, potential risk of harm, gives you a wide area of considering what is technically child abuse and neglect. 4 main types of abuse: physical abuse, sexual abuse, emotional abuse, which technically counts, and child neglect. So some statistics: approximately 700,000 to 1.25 million children are abused in America, abused or neglected in America annually. And then almost 3 million children are placed at risk for harm annually. I don't know what placed at risk for harm means, but it's on the CDC's website. That's their statistic of potentially abusive situations. I'm not sure how you calculate that. Approximately 18 of all abuse is physical, with the estimated range of a very little bit to about a third. It's estimated that only 5% of abuse and neglect is reported, which is highly unfortunate and makes your job even much more important to have a high index of suspicion, because pediatricians don't really see their patients regularly anymore. Our patients don't have one doctor that they go to all the time that knows them, and most of them use you guys as their pediatricians anyway. So you have unwillingly taken on the forefront of being identified. Trends over time, over the last 30 to 40 years in developed countries, have shown no real increase or decrease in the incidence of child abuse, despite having all these fancy laws and this increased knowledge of what abuse is and the risk factors. Demographic-wise, Hispanics and whites have the same amount, Asians a little less, African Americans and Native Americans a little more. No real reasons given for that. Perpetrators, biological parents, 80%. Non-biological parents and partners, 12%, which seems low because in my experience, just off the bat, it's usually mother's boyfriend. But just by the numbers wise, the biological parents are still by far the most common people to abuse and neglect their children. And then other adult babysitters, daycare workers, friend of the family. For specifics in abusive head trauma, they've done like who's the most common perpetrator of abusive head trauma, and there's your order. Fathers are the most common, followed by mom's boyfriend, and then a female babysitter, then followed by the mother. Just trivia. So they've isolated risk factors in the parents or the caretaker that leads to a higher risk of abuse. It's mostly the obvious stuff. Younger single parents, all the teenage single parents that we have that don't have our resources and don't know what they're doing. Low education level, unstable family situations, whether you're living on couches or you're moving from house to house or you're in the shelter, that lack of stability, lack of other financial and social support. Parents who were abused and neglected themselves, be it a learned behavior, that's how my parents, disciplined me, that's how it's going to be done, or they honestly don't know any other way to parent because that's all they learned, that's all they experienced. Doesn't excuse them, but it happens a lot, and it gets revealed more than you think that, later on, once the parent gets arrested, and it's revealed that they were beaten as a child or they were sexually molested as a child. And then domestic violence and child abuse commonly occurs together. It's another thing to think about. If a kid comes in abused, you should screen the parent, make sure there's not domestic violence going in between the parent in addition to the child. Any parent or caregiver with drug or alcohol abuse. Any psychiatric illness, you're more likely to abuse your child. And any unrealistic expectations for the child's maturity level. Parents who think that their 1-year-old should be potty trained get really pissed off when they keep, soiling their underwear. Think a 5-year-old should be able to dress themselves and cook meals for themselves without your assistance. Some parents have very unrealistic expectations, and when their child obviously doesn't meet those expectations, anger results. Some environmental risk factors, any stress factors within the family. And that can be anything. Divorce, money problems, arguments between the members of the family, any acute or chronic illness in a member of the family increases the stress. Losing your job, getting demoted, not getting promoted, or social isolation. It happens here, it happened a lot in the Midwest. Single parents, young parents would move from the middle of nowhere, come to the city, but they have no friends. They have no family within a 4-hour drive. And that isolation leads to increased stress levels. Considering poverty and low socioeconomic status, it used to be, if they're poor, if they have low status, they're increased risk of abuse. And they found that's not the case. Low socioeconomic status has pretty much the same rates of abuse and neglect as rich people. It's not a consistent risk factor in any of the studies that they've done. It's just detected more frequently, and it's usually detected earlier because we all have our index of suspicion with, impoverished children. Oh, is there abuse? Just, whether it's just stereotypes or we're more on guard for it. So we have a higher index of suspicion and thus, start workups a little quicker, a little earlier in other people. And then child abuse in affluent families is hard to detect. They have a lower index of suspicion just because people, these well-to-do parents, they would have no reason to beat their child. So you just assume that it's not happening. So you have these borderline kids that give them the benefit of the doubt. And it's easier if you have lots of money and lots of connections to get out of it. Avoid being detected, avoid punishment if you are detected. And then concerning the child themselves, younger children, especially less than 3 years, are more at risk for abuse, mostly because they're nonverbal. The caregiver, they couldn't tell anyone, even if it happened. They cry more. They can't do anything on their own, leading to those increased stress and anger levels. Any child who's been abused in the past is more likely to be abused in the future. And studies have shown children return to their families after abuse, whether immediately or later on, have a significant incidence of recurrence. Any children with medical conditions are at higher risk of abuse. Speech and language disorders, failure to thrive, any congenital abnormalities, be it physical or developmental, intellectual disabilities, obviously, or any regular kid with a chronic or recurring illness, hemonkers, sickle cell anemics, chronic illness. They have to be at the doctor every month. They have all these medications that the parents may or may not be able to afford. And children with ADHD, just because of the behavioral issues and the frustration of the caregiver increases. Any non-biological caregivers are just statistically increased risk of abuse. And colicky babies, just because they cry and they don't stop, and at some point, parents just get frustrated to the point where something happens. Clinically, The most common type of injury in abused children is bruises. You don't have to hit someone too hard, especially a little child, in order to get a bruise. Now, I give you this timeline with a caveat that it has never been proven reliable. You can't look at something green and say, oh, that happened 6 days ago. But approximately, this is the trend of how bruises evolve over time. Swollen and red, black and blue, and then as it fades, green, yellow, brown. But again, you know, I have ACS workers and police all the time. It's like, oh, when did this happen? Sometime in the last 2 weeks. I mean, you really can't do much more than that unless it's an obvious fresh injury or there's no injury at all. Normal child bruising areas are over bony prominences on the extremities. Example, forearms, front of the shins. If you have children, they fall all the time, and that's where they fall. Including the forehead. You don't learn to put your hands or arms out in front of yourselves until you're 4 years old, 5 years old. Everyone comes in, they land face first because they just don't put their hands on it. Abnormal bruising areas, center mass. Kids don't belly flop when they fall. Bruising on the torso, on the back, buttocks, genitalia, cheeks, earlobes, inner thighs. These are not common places for children to get injured in normal play and rambunctious behavior that should raise suspicion for you. And the posterior thigh and the calf. Squishy muscular areas. Little kids don't fall and hurt themselves in those areas very commonly. And then this is going to be a recurring theme. You have to correlate your exam with your history and the child's. I'm sure you've always had, oh, my 2-month-old rolled off the bed. No, he didn't. My 6-month-old was cruising and walked and fell. That absolutely did not happen. You have to have your knowledge of what the kid can do correlated with the story. Normal childhood bruises do not occur in shapes and patterns. Bruising is blobs over the bony prominences, where you fall. There's no shapes, colors, designs in bruising. Anything where you can make out handprints is unlikely to be accidental. Repeated poking marks give you these oval bruises, but they're going to all be the same size. That should raise a suspicion. Any lines, doesn't have to be bruises with linear patterns. You can just have petechiae and not the actual bruise itself. Loops, belts, or anything that doesn't seem a normal blob should be suspicious. First bad picture's coming up. 2 on the left, handprints. I mean, you can clearly make out the fingers. That is not a normal, I fell on my face bruise. Top center and top right are fingerprints. You can see the kind of the repeated, mostly the same sized oval shapes. And then the bottom right is a hand, and then the bottom middle is a rod or a stick. These linear patterns. Kids don't fall on linear things in these, and that's in your thigh. They don't fall on the side of their thigh very often. Loops, belts, none of these are normal patterns. All right, so anything in a shape, in some sort of arrangement should be suspicious. People don't get bruised on the neck. Kids don't fall on their soft tissues of their neck. They should never have bruises there. The cheek, kind of in the middle on the top. Does anyone know what that is? It's a brush. Hairbrush. You whack them, you get all these little pinpricks. I don't know much in nature outside a porcupine that's going to cause that normally in a child. Bites could be part of physical or sexual abuse. You'll have these circular or elliptical bruises. You may have central clearing, or the entire inside might be bruised or have petechiae in it as well. Human bites are going to be superficial. No humans have these long canine teeth. Animal bites have puncture wounds. Cats, obviously, even dogs, they're going to be deeper. Humans do not cause deep injuries. They're very superficial. They usually don't even go all the way through the skin. Lots of times you can make out the individual teeth. Good rule of thumb, hopefully you'll never have to use it. but if your canines tooth marks are more than 2.5 centimeters apart, then it's not the sibling that bit them. Because lots of times, oh, the little brother did it in any of these things. That's something you can quantitatively use. That's an adult bite mark. Most are not visualized the day of, but they will evolve over the next 2 or 3 days. So you can see kind of various, newer, and then as it fades, these are crappy pictures, but kind of green to yellow. Second most common injury of child abuse, broken bones. There are many patterns that are suggestive of abuse, but there's no one fracture or one location that you can pinpoint and say, this is absolutely abuse, no other way. But there are things that are much more likely to be non-accidental. Again, associate the fracture with the patient. Toddlers' fractures happen in toddlers who are cruising. They don't happen in 6-month-olds who cannot stand yet. Long bone fractures require a decent amount of force to break them. So if you have a little baby that's not doing much movement, they can't generate force to break these long bones. Development of fractures, initially soft tissue changes, swelling, fat pad on the supercondylars. The soft callus, new bone formation, usually is 7 to 10 days, sometimes a little earlier. About 2 or 3 weeks, you have the fracture blurring as the new bone goes in. You don't have these sharp fracture lines anymore. And then you have your hard callus, which eventually will dissolve. Fractures that are highly suggestive of non-accidental injury are metaphyseal corner fractures. I'll pictures of a lot of these in a little bit. Corner fractures are kind of classic abusive fractures. Rib fractures in children, very hard to do. Sternum, scapula, spinous process, it's not a very naturally occurring fracture. Multiple fractures in various stages of healing, obviously. Bilateral long bone fractures, you get the bilateral forearm fractures in a kid who unfortunately landed at the same time, but it's really hard to get bilateral humerus fractures, non-accidentally. Any long bone fractures or severe fractures that don't have a history of, I was in a huge car accident, or I fell out a second-story window. Finger fractures in kids less than 36 months, unless something obviously happened. I broke my finger when I was 8 months old, but I was crawling and my mom dropped a steak on my hand, frozen steak. That's a story. But, I don't know, he was playing with the toy and then he started crying. It's not natural to have these finger fractures. Or any complex stellate nonlinear skull fractures in children under 18 months, again, without an obvious traumatic history. Long bone wise, femur is the most common long bone fracture, followed by the humerus and tibia in non-accidental cases. Isolated femur fractures in children less than a year, they've shown that the vast majority of those are non-accidental. How does a 1-year-old gather enough force to break their feet when they're not really moving? Again, correlate their developmental status. And then the American Academy of Orthopedic Surgeons has said any children under 3 years with a femur fracture should at least initiate a workup for other injuries for non-accidental trauma. Long bone shaft fractures. The single acute fracture is the most common fracture pattern in abuse. They're usually transverse fractures from the direct blow perpendicular to the bone. Spiral fractures, on the other hand, are much more commonly accidental, especially your toddler's fracture, which is your spiral fracture of the tibia. You can compare. The left is a transverse fracture. It's not very common to have that happen falling while walking and cruising around. On the right, on the other hand, it's very common for young children to have falling, twisted. I had a kid who got his foot caught on a slide at the playground and snapped his leg like that. That's going to happen in your spiral pattern. The one on the left, that's from a direct blow perpendicular to the bone, much less common. These corner fractures are 10 to 30% of abuse fracture injuries. Your classic is the corner fracture or the bucket handle fracture, and it's the same fracture, it just depends what angle you get on the x-ray. There's the two different names for how they look. This is considered highly suggestive. I would say this and posterior rib fractures are kind of the two classic abuse fracture patterns. Not to say they can't happen accidentally. Highly suggestive, especially with a non-ambulatory patient, more than one of them. And this is a twisting or forcibly pulling force, but it's a lot of twisting the arm, twisting the legs, yanking on an extremity. And it gives you an isolated fracture of the metaphysis, resulting in this bone fragment. Many of these are asymptomatic. They won't have enough pain that they won't be using their arm or they won't be walking around. They might not even be point tenderness, depending on how old it is. So there's your picture of it. So on the right, you have your bucket handle. You have the whole kind of head of the bone fractured, isolated. That's your bucket handle. You have your corner, and it's the same thing, but turn it in your different viewpoint, and you get these little corners where the arrows are pointing. The one in the middle actually has both. You have a corner on the top and a bucket handle on the bottom. But if you see these, you should at least initiate a workup, make sure nothing else is going on. Rib fractures, direct blows, compression to the chest, commonly from these squeezing forces. So you can see by the hands, that's where you get your posterior rib fractures commonly, closer to the center to the vertebrae. You can get these from shaking injuries, not even if you're not squeezing tight enough. Children's ribs are not like old people ribs. They don't snap very easily. They're very flexible, so it takes a lot of force to break them. And they've done CPR studies with infants, and routine CPR in infants is usually not enough to cause rib fractures. So, on autopsy, medical examiners know this, but just because they got CPR doesn't mean that's how they got their rib fractures. Usually they don't have external signs, bruising, swelling over the skin where the fracture is. And again, excluding significant trauma in the history, presence of rib fractures in children is a high probability of abuse. They're usually not displaced, and they're usually multiple rib fractures in a line. You'll see them going down the line, 4th, 5th, 6th rib. X-rays are tough on these kids because they're usually non-displaced, so how are you going to see an acute rib fracture that happened today? There's no fat pad, you're not going to have a callus. So in these kids, it's why the official recommendation is for skeletal surveys, you repeat them in 2 weeks, because then you see the callus formation from injuries that were too acute to be seen on the initial exam. But you do need to do, your AP and lateral will not find rib fractures. That's why in the skeletal survey, you do the bilateral obliques. You twist them at 45 degrees so you can see the full ribs on each side. So right side, right here, you can see the callus formation. This is a follow-up x-ray 2 weeks later. And then it's just a zoomed in. And this is what you see in the x-rays. You don't see these the day of, the day after. You have to, this is an older injury, you have to wait for callus formations to see these rib fractures in the vast majority of the time. Facial injuries, ear bruising, the pinna, the auricle, it's not a common place to accidentally bruise, but it is a common place from pinching of the ears and squeezing. Old school grandmothers used to do it. You're not really allowed to do it anymore. You get bruising, squeezing in the ears. Any cauliflower ear in someone who's not a wrestler. And oral injuries, tongue injuries, frenulum tears, gingival lesions, unless they have a history of, oh, he fell on this thing on his open mouth. See kind of these top two on the right are frenulum tears. Most commonly, they are from forcing the pacifier in the mouth or holding the mouth closed and putting pressure. You'll see this bruise right here. It's from someone trying to put pressure over the mouth of a crying baby to get them to stop. But the most common reason for these frenulum tears is shoving the pacifier in the mouth forcibly. And then you can get traumatic alopecia, this patterned alopecia without, a tinea cap history, something like that, from pulling the hair out. And with traumatic alopecia, you can also get kind of these cephalohematomas underneath from just the trauma and pulling the galea layers apart. Burns-wise, again, history and physical exam, you have to correlate the story with the burn you're seeing. Because it's easy to make up a story about a burn, and it's your job to see whether it's the right story. Skull burns are very accidental, but they can also be forced. It's important to just look at the pattern and recognize, does it match? If you pull down a hot pot from the stove and a little kid, it's going to drench you in a pattern. It's not going to be isolated to only your back. You don't pull something down and have it only hit there. Right? You have to be able to detect it. Any obvious pattern or abnormal shape is suspicious. Cigar burns, pattern burns, stun guns that aren't brought in by the cops, any brands or contact burns where some flesh was put against a burning device, or immersion burns. I have pictures of that, unfortunately. So any patterns. Top right is a clothes iron. So the bottom right is a immersion burn. They put the bottom of the feet in hot water. And this bottom left is an example. If you put a baby, you hold them down in a bathtub, you're going to have this sparing of the buttocks, and they call it a donut sign. If you hold it down, your butt's against the floor, so that skin doesn't burn, but everything exposed burns. So you have these weird patterns on the bottom from holding down. And then it's just various patterns. People burn their kids with that. So immersion burns, you get this mitten, stocking, glove pattern of putting the extremity under the water, putting the face in hot water. I had a baby that looked like this, and the mom said she just woke up and all the skin was peeling off. Woke the baby up from a nap, she had no idea what happened. And she tried to get away with that story for like 3 hours. But that does not happen waking up from a nap. But that's the pattern. You have clear linear markings at the edges of the burn. That's not a splash injury from something falling down. And then patterns, cigarettes, big lighter. And then these are stovetops, sitting on a stovetop. Head trauma. It's called abusive head trauma now instead of shaken baby syndrome because it happens from other things other than shaking. Usually your classic injury pattern is unilateral or bilateral subdurals with retinal hemorrhages and this diffuse brain injury. Most occur in the first year of life. Your median age is about 4 months. So you have 2 types of injury. I mean, you see it in your non-abusive head trauma, but you have your primary injury from your translational and rotational forces, and then later on they give you ischemia and hypoxia that are found on MRI. So head bleeds, significant head bleeds rarely occur from low energy falls. Falls from changing tables, fell out of the bed unless it's the top bunk. Fall from stands while running around. Don't get big fractures and bleeds from those things. These kids don't have enough speed or force to make that much trauma. Your annual risk of falls, and short falls in infants less than 4 feet is exceedingly low. It did a study in '99, falls less than 4 feet, infants under 10 months. 1% had serious intracranial injuries, and both of those were abuse. You can get, and only 7% had linear skull fractures without bleed, which is your common fall, simple fractures. But if you have a low impact history and a bleed or some unusual fracture, it doesn't happen naturally very often. Epidurals are more common in accidental injuries, linear falls, over the parietal. You can even have retinal hemorrhages with accidental epidural hematomas in the falls. Subdural is unusual accidental in children. They can occur from birth trauma, but evidence of that is gone by the end of the month. So you're not going to have a 2-month-old with the subdural blamed on the traumatic forceps birth. And then you can have multiple subdurals of differing densities depending on how long the abuse is going on. Subarachnoid is present in pretty much all the fatal cases, but other than that, it's not very reliable. They happen pretty much equal incidence in accidental and non-accidental. Parenchymal injuries also occur. There's no good pattern to detect whether it was accidental or not. Spinal injuries happen very frequently when there is an abusive head trauma. Most are not clinically evident, not evident on CT scan, but they are they usually found occult on MRI. So your evaluation of this. History is the most important thing. You have to get your story. Your story has to match. You have them repeat the story. It's good having residents and a social worker because that means the parents have to give the story 3 times. And it needs to be the same all 3 times. It needs to be the same across the different people in the home. You'll have the dad say, oh, he fell out of the bed. You'll have the mom say, oh, he fell off the kitchen table. Which was it? You let the parents tell the story. They will very commonly dig themselves in a hole without you even trying to help them. What happens, and you sit there and listen, and the story will reveal itself. It'll be obviously doesn't make sense, or obviously they'll unwillingly incriminate themselves or incriminate someone else. You can ask questions to verify details, but again, like with your kind of sexual assault interviews, you don't want to ask them leading questions. You don't want to give them easy yes or no answers. Any suspicious history, vague. When did it happen? Oh, a week ago, maybe 2 days ago. He might have fell. Any history that's inconsistent with the injury, obviously. Changes to the story over time, or no history offered. Baby woke up like this, I have no idea what happened. Or any facial injuries in the kid that's not moving around. General appearance, how do they look? Do they have new clothes? Are their clothes washed? Do they look like they haven't taken a bath in a month? You want to do a full exam, you want to examine them, every part of the skin. You can't just leave the diaper on, leave the, unzip the onesie and look up the belly. You have to look at every exposed piece of skin in these cases to find, because being the parents, well, sometimes they'll abuse the kid in places they don't think anyone will look. If there's suspicion on the workup, opto will obviously have to evaluate for retinal hemorrhages. Again, suspicious finding are your pattern injuries, anything in